Okay, hello, good evening, everyone. I hope all of you are watching this video are in good health. So today I came to live on Facebook about some topics from the pediatric guideline. That is a very common book for our Mrcpch exam, especially for the FOP, that is Foundation of Practice. This FOP exam mainly is guideline based. The questions will be like scenario, and they will ask the management. So we know as our Mrcpch has two parts exam, that is part one, and part one has FOP and tasks. So that's why I came here today to discuss about some important topics from the pediatric guideline. So let us start our today's session. I hope you all will be watching from the YouTube. So let us start. So this is about my teaching session, few important points so that people came to know. They are asking, keep me asking in the groups and in the Facebook and WhatsApp that, Madam, I want to know about your courses. And also they want to ask me some common questions of Mrcpch. So this is the website. This is the website I will tell you to go. Okay, this is the website. Can you see this, my cursor? This website, if you go in this website, everything related to the exam they published. This is the official site of Mrcpch. In this site you will come to know about all three exam, that is Mrcpch part 1, part 2 and clinical exam. And also in this website everything is written, like fees, when the exam window is opening, I mean when you can book your exam, and how you should register your Mrcpch account. So if you go on this website, you can easily get through all the questions that you have. So some students asked me that how many questions does the Mrcpch have, and what is the passing mark. So actually part 1 Mrcpch questions are like 90 to 100 question, it varies. And there is two paper. In the morning it is usually FOP exam, and in evening task exam. And you will be given pass mark according to the examinees that are giving exam, and according to the passing mark of the question pattern. Suppose the question pattern is very tough, then the passing mark will go down, and the question pattern is very easy, then the passing mark will go up. So the pass mark actually varies, it is not a fixed. Okay, like 55 to 75, it varies every year. Every term passing mark is different. And question also varies. Sometimes question they give 90 question, sometimes they give 100 question. Among them 7 to 10 are extended matching questions. Extended matching questions actually are the questions who have answers, many answers, and 3 question. You have to search for each question 1 answer. Okay, this is called extended matching. Every question has 3 stem, 3 different question. And single best answers are the rest of the question. So around 21 to 30 question will be EMQ, and the rest, suppose rest 70 question will be single best answer. And in the single best answer there will be one answer correct for each question. Time usually 2.5 hours, it is fixed. And exam, now in the COVID situation, exam is going on both online and offline. I mean, you can give exam in hall, exam hall, if the country is less COVID infected, then they are conducting exam on the center. And in some countries where the COVID situation is not good, they are conducting exam online. In last year 2020, many of my students they passed from online invigilator. I mean, the exam was totally online. So you can also try, if your country does not have any center, you can also try to give or book online examination. Now the main question is coming: how many exams how many exam is the in a year? I mean, how many times exam occurs in a year? So in part 1 exam, there are 3 sessions per year. That is February attempt, you can go June attempt and October attempt. And every year passing marks actually varies. Question pattern remains same, but the passing mark actually varies. Okay. Now the most common question that I face, that is the books. That madam, can you tell us the books of Mrcpch part 1? Actually, there is a lot of books you can go through, but most importantly, you have to follow the guideline. That is the Mrcpch, RCPCH, they follow the Royal College guidelines, NICE guidelines, and some trust guidelines. Okay, so these guidelines are published in UK from different hospitals, and some guidelines are published from NICE. And these guidelines both are separated, like a pediatric and neonatal guideline. So you can go through among the pediatric and neonatal guideline. And there are red book, I will show you today. There are red book and neonatal blue book guideline that that is very important for our part 1, not even part 1, for Mrcpch, AKP, and clinical also. You have to follow these guidelines. So stick to the guidelines. And there are many leaflets in the website. Like if you click like www.constipation NICE guideline, like this, then the constipation related all the NICE guidelines will come out. Okay, so you can download from directly from the Google. Okay, and there is another website that is called the Patient Info website. And in that website, in from England, they publish different guidelines related to every subject: pediatrics, gynecology, and medicine, surgery, every subject. So we can go in NICE guideline from Google, and we can go from Patient Info website. Okay. Among the books, FOP cases book, that is the yellow color, FOP cases book, 50 cases, that is very important. And ethics related chapters, you will find ethics related chapters in the red book guideline. Also, ethics is in every book. Like in task cases book, you will find some ethical questions. In FOP cases book, you will find some ethical question. So ethics is not a different book. Basically, ethics you will find in every chapter, every book. Like Science of Pediatrics has chapters of ethics. Okay, you have to read from that book. Same as palliative, there is no such book for ethics and palliative. You can find it in every book of RCPCH, for Mrcpch. And also you can go through Patient Info website for palliative question, like how we take care when a child goes under the palliative care. In Patient Info they have written everything, like pain control, how we use pain control in palliative care, what is palliative care, like this. Now comes to recall. Recall is very, very important. Recalls are the question that are that came in the past exam. And these recall question are important because 20 to 25% questions usually they try to give from the recall, so that the question pattern remains same. Okay, and the students does not biased or does not misguide. So in RCPCH they try to give some old question, and these are called recalls. So these recalls are very important. You have to read these recalls very well. But the main problem is that the recall are the question when people are giving exam and then they are coming back and they write down those questions. This is recall from the brain. So the recall from the brain will be like it will be sometime misleading, and some points will be incomplete. So when you are reading recalls, don't misguide by the question. Just try to focus what was the question and from which topic this question is coming. Okay, so don't be misguided by recall question. You just focus on the topic and how the question is coming. Like they are asking, sometimes they are asking some investigation of some disease, sometimes they are asking the management, sometimes they are asking the gold standard management. Okay, this is recall. Now sample papers are the sample question that is released by RCPCH when you are booked for an exam, and then RCPCH will send you some question. These are sample paper question for every exam. Like if you book part 1, if you book part 2, if you book clinical, they will give you this sample question. So sample question are like 10 to 15 questions they will send in your mail. This question, when we are reading, we are collecting in a folder, and these are sample paper question. And these are important in a sense, they are directly coming from RCPCH. So sometimes in Mrcpch exam we will find this direct question. Okay, so these are sample paper question. And as I told before that there are other books in Mrcpch, that is the survival guide or illustrated textbook. And these books, survival guide, illustrated textbook, these books are not dedicated for Mrcpch exam. Okay, like the previous books, guideline, FOP cases book, science of pediatrics, they are dedicated. But these two books, survival guide and illustrated textbook, these two books are not dedicated book. They are some chapters you will find important to read. Okay, so you can go through these chapters, survival guide, illustrated textbook. If you find that you are not understanding some topics like genetics or metabolic chapter, you can go through the survival guide. Illustrated textbook has some good chapter like child development. You can go through the child development chapter from this illustrated textbook. Okay, now next is task cases book. So for the FOP exam, similarly there is a clinical cases book that is called task cases book, a similar book, 50 case. So you can go through this 50 cases book. And 50 this 50 cases book actually have 50 chapter related to one system. Some chapters you will find it is related with cardiovascular system, some chapters you will find related with gastrointestinal, some you will find neurology, some will dermatology. So this task cases book is very important in a sense that it gives you an idea about the task question. Okay, and science of pediatrics book, it is the mother book. Okay, it is the mother book of task exam. This book is comprised of composed of everything like anatomy, physiology, then basic structure, and then you will find like the question pattern, pharmacology question, all the questions that are coming in our task cases, task exam, you will find in this science of pediatrics book. And the science of pediatrics book will help you in understanding the disease pathology. Okay, also treatment process, pharmacology, it will be important. And ethics and palliative, as I discussed, ethics and palliative are the common topics, common chapters that will be important for both our task exam and FOP exam. So if you read ethics and palliative, it will be helpful for both the exam. Now pharmacology is an important chapter for our Mrcpch exam. But pharmacology, basic pharmacology question will come in tasks, and some question related with some disease, suppose ADHD, okay, attention deficit hyperactive disorder, ADHD drugs or autism or some other disease drugs, they can come in FOP exam. But basically pharmacology is a dedicated for task exam. And what kind of question are coming? Any topic that like cardiovascular or neurology, any system related drugs, anti-epileptic drugs, antihypertensive drugs, anticonvulsants, and diuretics drugs. Okay, furosemide, thiazide, these basic mechanism of action, their side effects. okay, and which type of disease we are using which drug. So these are the pharmacology question. Some question will be given very basic, like pharmacodynamic property, then half life, what is called half life, then pharmacokinetic, what is the definition of pharmacokinetic, then what is zero order kinetic. So this basic pharmacology sometimes the question will come. So pharmacology is an important topic in a sense that you have to understand when you are treating a little child, treating a pediatric population, you have to understand the side effect. Okay, you have to counsel the parents about the side effect. You have to keep in mind what kind of side effect can be so that you can take precaution. So pharmacology, I will tell, it is a very, very important topic for MRCP or any exam. Okay. Now, basic subjects, there will be some question that is related with basic subject like anatomy, physiology. There is no specific books for this basic subject, but you can go through your anatomy notes previously when you read in your MBBS. You can go through USMLE Step 1 book. Okay, that book has many that book has many basic topic like anatomy, pharmacology, pathology, microbiology. So this question will be in the task exam. Okay, sample paper and recall, as I discussed before, it is same for task exam and FOP exam. So you have to follow these questions. And statistics is an I mean, for many students it is a very tough topic. Okay, so statistics you have to understand, because after passing the exam you have to do certain research. You have to take part in quality improvement project, audits that are happening in your training center, in your hospital. You have to take part in that. So for future training, for future understanding, you have to know now what is statistics and why what is the importance of statistics in our daily life, or what basic question comes from statistics. Okay, for this MRCPCH part 1 exam, we have a book, Statistics for MRCPCH. You can read that. And also in my teaching sessions, I have a very fantastic lectures I give, and I also have some notes, some tips how to memorize. So we'll understand the basic statistics from our case, from our class. Some people ask me, Madam, what is the prospects of MRCPCH, from which country I can work, I cannot work, like this. So this is of course the highest postgrad degree in UK. After this degree, there is no other degree you have to pass. This is the highest postgrad degree. And after passing MRCPCH, you can work directly as a specialist. Some students, after passing, act directly as consultant because they are highly qualified in their own country. So they go in UK and they work as a consultant. And in Bangladesh also, they have a high value. Okay, in any private sector, in any private hospital, you can work as a consultant after this MRCPCH exam. Now, if you have any question, I will I invite you to join my teaching sessions. And also, if you have any query, this is my number. You can join for the course. And also, if you like to ask any question related to MRCPCH, you can ask me directly in my number, and I will try to answer in my next free session. Okay, so as I promised you today, that I will take some topic from Red Book Pediatric Guideline. So now I'm sharing that one. So this is the Red Book Pediatric Guideline. Okay, this is a very common book, and we all know this book. So this book is very, very vital for our MRCPCH exam, because you have to know the basic basic treatment, basic rule, basic investigation for any disease. Like RCPCH has a very nice, excellent guidelines for every disease, each and every disease, like for diarrhea, for pneumonia, for constipation, for cystic fibrosis, for any disease. RCPCH has this guideline they are published. when you are reading, or when you are reading this guideline red book, also you can follow the guideline from nice guideline. Some topics are missed because this is, this is partners of pediatrics, and this book, this partners in pediatrics, this is published by many different trust, many different hospitals in UK. So they are mixed up. So some topics are not present in this book, like Crohn's disease. Okay, this is not present. Then ulcerative colitis is not present. Then chronic management of asthma, this is not absent in this book. Like how we are managing a child of asthma that is stable. Okay, this book has the management of acute asthma attack, but chronic management is absent. So not that this book is self-sufficient 100%, but nearly 90% it is sufficient. And every topic is not important. You can just read some topics, just reading, and some topics you have to understand and memorize very well. So let us start our today's session about this guideline. Okay, so we will try to read some important guideline today. Okay. So this is our first guideline. Uh, this is the abdominal pain. So when you are reading, how to memorize this vast guideline in a short time, okay, short period of time. So this is, suppose when you are reading abdominal pain, you have to understand first of all, you have to understand the which abdominal pain is alarming and which abdominal pain is stable. Okay, this is the first important understanding. Whenever you are reading in any disease in pediatric population, you have to understand that which signs, symptoms the child is tolerating and for long time, like chronic, and which sign symptom is acute. And if it is acute, what is the red flag sign, what is the alarming sign that I should be very aware of, and I should be very rapidly thinking about the diagnosis. So in certain cases, rapid diagnosis is important. And in those cases, if we miss the diagnosis, the result will be very fatal, right? So that's why our discussion about this guideline is mainly you have to understand the red flags of pediatric disease, and also you have to understand the cause, the investigation, the sign, symptoms, and the management plan. So divide each guideline into 4 areas. First of all, what is the cause of this symptom, and what are the sign, symptom, and what investigation I will do for this disease, what management plan I will give. Now, when you are reading the investigation, there are certain investigation like gold standard investigation. Gold standard investigation is a changing topic. Remember, 10 years back in medical science is rapidly growing, right? It is not static science, it is a growing science. So in 10 years back, medical science was gold standard investigation was something different for Down syndrome. And 10 years, after 10 years, a gold standard investigation of Down syndrome is totally different. So the gold standard investigation, gold standard drug is a changing process. Don't think that it will be fixed. Like when I was intern 14 years back. Okay, so at that time, the treatment protocol, now the treatment protocol 14 years back, I find it very, very changed. Okay, so medical field is a continuously progressing, continuously developing field, and that's why the gold standard investigation, gold standard management will be changing. Okay, so In MRCPCH part 1, from this guideline, you have to understand the definition of any symptom. Is it chronic and is it acute? And what is the red flag of this disease? And what is the best investigation to diagnose this disease? And what drugs are best first line drugs? Some drugs you will find it is important for second line, some drug you will find important as third line. So you have to understand the basic first line drug, second line drug, first line investigation, second line investigation, like this. Okay, so let us start with this abdominal pain first of all. So abdominal pain will be different in different age group. Suppose a child neonate, his neonatal abdominal pain and a toddler abdominal pain and adolescent abdominal pain, the pain symptom will be different. Neonate will cry, inconsolable cry, and you cannot console the child. The child will be very irritable, not feeding, okay, sometimes not peeing, I mean not passing urine, not passing stool. These are the signs symptoms of abdominal pain. And in toddler they can be also very irritable, restless, they can show the tummy, they have tummy ache, okay. And in adolescent, like adults, they can rapidly tell you, and they can rapidly identify the location of the pain, and they can they can tell you the other symptoms of abdominal pain. So symptom and sign of abdominal pain related, we may be related with vomiting or constipation or loose stool. Then there may be fever, there may be the character of pain can guide you sometimes. Like if it is colicky abdominal pain, think about some visceral problem. Okay, if it is burning pain, think about some gastritis like pain. Okay, and the what is the character of pain of acute appendicitis? The McBurney's point will be tender. Okay, and what is the character of pain of acute pancreatitis? The child will be leaning forward and he will be in severe pain. That is the pain of acute pancreatitis. So the pain in visceral organ of abdomen is different. Okay, so you have to understand that what is the age of the child, what is the presentation of the child, and what is the pain criteria of the child. Now, typical causes of acute abdominal pain in children. So as I told during the first part of the topic, that pain will be two types. It will be acute or chronic. So sudden onset pain, what are the causes of sudden onset abdominal pain? It can be just 1 minute. Yes, please. Okay, so pain can be two types, acute and chronic. What are the causes of sudden pain, acute pain in children, in pediatric? It can be related with infection, like acute appendicitis infection or obstruction. Okay, this will be acute abdominal pain. And there may be history of low-grade fever. Sometimes the pain will be migrating from one side to another side. If there is any perforation, there will be guarding and rebound tenderness. And if you palpate or percuss the abdomen, the child will feel pain. Okay, and as I said before, like young children who are very, very small, they cannot locate the pain. The pain will be the symptom will be irritability, like they have respiratory distress, diarrhea, vomiting, and sometimes even they cannot walk, limping. This is another sign of abdominal pain in a small children. Now, there are different conditions of pain, like appendicitis, the pain is different, but the intersusception, the pain is totally different. Okay, there will be arthritis, there will be abdominal, colicky abdominal pain, and at the later stage, the child will pass red currant jelly stool. Red currant jelly stool is the indicating very advanced intersusception. Why? Because it is the indicating the it indicates the necrosis of the sloughing. Now, who can tell me, anyone can tell me, please open your mics, anyone can tell me that what is the basic pathology of intersusception? I mean, what is intersusception? Can anyone tell me? from here, from the students? What is the
And
best
so
analogy
it's
here?
kind of invagination of one part of the intestine into the other.
Other part, yes, very good. Invagination. So which part is invaginating to which part? I mean, proximal part is going inside or distal part is going inside?
Proximal.
Distal part is
Distal
actually,
part.
distal part is going
Yeah,
inside.
yeah, yeah. Distal part of the, yes, yes,
Yeah,
sorry.
yeah, distal part is going inside. So this is called, so this is just like telescope, you know, this is just like telescope. Suppose this is the organ, this is the intestine, and some part is invaginating into there. This is another part. So this part is invaginating here. Okay, so this will compress this side, you know, this will compress the wall of the adjacent intestine, and there will be bleeding, there will be blood mixed stool. Okay, this is intersusception. And in intersusception, you will find colicky abdominal pain, you will find colicky abdominal pain, you will find sometimes you will, if it is associated with Henoch-Schönlein purpura, there will be arthritis, joint pain. Okay, because the children who are more than 2 years of age, they have a highly tendency of Henoch-Schönlein purpura and associated with intersusception. And the child, sometimes you will see the scenario of hypovolemic shock because of this passing of the red currant jelly. The child is dehydrated. Okay, there will be blood mixed stool, so the child will be in the hypovolemic shock. Sometimes you will find that there is a sausage shaped mass, but this is not typical. Okay, sometimes you will find in the right upper quadrant or in the epigastric or behind the umbilicus, because the the part is not fixed. The part is not fixed, which part will go inside which part. That's why you can find it in right upper quadrant or in the epigastric region or in the umbilical region. Okay, clear until this point? So what is the treatment? If the child not in shock, then we will give treatment that is supportive. Okay, and we will try to reduce the intersusception part by the enema, air enema. Okay, and sometimes we reduce surgically. If air enema failed, then we reduce surgically. So this is the treatment of intersusception and the presentation of intersusception. Now, some abdominal pain will be due to lung cause. I told you that abdominal pain, abdomen is a very mysterious site. It is a magic box. Okay, so pain can be referred from hip joint, from thigh. Pain can be referred from lungs. Okay, if there is a basal pneumonia, empyema, you will file abdominal pain. Okay, other abdominal pain are surgical cause mainly, like acute appendicitis, intestinal obstruction. They are very acute and sudden onset and severe pain. Okay, just 1 minute. Someone is asking the Zoom link. Okay, so this surgical causes will be acute, very acute cause like intestinal obstruction and torsion of the ovary or torsion of the testes. And Meckel's diverticulum is, we know Meckel's diverticulum is 2% population. They affect by this. This is the embryological part. Okay, sometimes this Meckel's that is the diverticular structure, extra structure that is inflamed, and that create a inflammatory condition, and that create a sudden uh, okay, that create a sudden severe abdominal pain and also bleeding. We will find in Meckel diverticulum there is bleeding. Okay, now renal or biliary calculus, they are also very acute condition. And enterocolitis like Hirschsprung disease, if it is infected, then we know this is called toxic megacolon or enterocolitis. So this is also they can present in acute abdominal pain. Now, the medical problem are relatively common, like mesenteric adenitis, constipation, gastroenteritis, inflammatory bowel disease. These are the common medical condition in pediatric population with abdominal pain. Okay, and also, as I said, pneumonia, pyelonephritis, phenolphthalein purpura, hepatitis. These all. So every system has a medical condition for abdominal pain. Now, some abdominal pain that are very rare but very important, you have to understand the basic pathology, why they are causing abdominal pain, like lead poisoning. Okay, lead poisoning has anemia also. Abdominal lead poisoning can present with constipation, so followed by abdominal pain. Diabetic patient can present with gut ischemia. We know that DKA, diabetic ketoacidosis, one important finding of diabetic ketoacidosis is hypovolemic shock, acidosis, and abdominal pain. This is the three most important common symptom a child will present. Okay, then sickle cell crisis will present with thrombosis and ischemia, so they have abdominal pain. Porphyria, then pancreatitis, severe abdominal pain, acute pancreatitis, then peritonitis and non-accidental injury. We have to remember that in UK, in our Mrcpch exam, this non-accidental injury is the last thing that should be in your mind, but you should not forget this term, non-accidental injury, because in pediatric age group, the smaller the child, the chances are abuse, more chances of abuse. Okay, so non-accidental injury should be in your mind. If you have any suspicion, suppose the history is not matching with the presentation, then the chance of non-accidental injury is high. You are seeing the child is very, ugly, very dirty looking. I mean, by look you can see that there is no care, no one is to care the child, and the teeth are dirty, the clothes are dirty. So in those cases, you have to understand there may be a possibility of non-accidental injury. Okay, raise your suspicion in that case. So we should not forget this in any disease. Now, the gynecological problem, like if the child is teenager, you have to think about pregnancy or cyst, ovarian cyst, or miscarriage, okay, PID, then mid-menstrual pain, that is ovulation pain, and imperforate hymen. So you have to think about when the child is in teenager. Now we finished our acute abdominal pain, the causes and the management. Now think about the chronic abdominal pain with red flag. So chronic, why chronic is related with red flag? Because in acute abdominal pain, usually we refer the patient suddenly, but in chronic abdominal pain, we don't refer suddenly. We used to look or observe the child, but there are certain symptoms when we will not observe the child. What are the symptoms? Like if the child has persistent vomiting, more than 3 times vomiting per hour, okay, and the child is not taking any food, whatever she takes or he takes, he's throwing up. So this is the persistent vomiting. And family history of IBD. Suppose the first cousin, second cousin, family, parents or brothers, sisters have IBD, so you have to suspect IBD from chronic abdominal pain, or any family history of celiac disease. And PUD also is an important condition you should not forget. Some students think that PUD will not be important for us for part 1 pediatric. No, pediatric population also suffer from peptic ulcer disease. So Helicobacter pylori infection, okay, acute gastritis. So peptic ulcer, eradication of Helicobacter pylori, we have to understand. Then dysphagia is a medical term, but dysphagia is if the dysphagia is acute, okay, and it presents with chronic abdominal pain, you have to refer the child. Now there will be some blood loss or problem in the joint, or perianal disease, weight loss, fever. These are the red flag for chronic abdominal pain. If chronic abdominal pain, that is pain for more than 6 months, associated with this sign symptom, please refer to the gastroenterologist. Okay, so this is the red flag. Now, investigations of pediatric abdominal pain. Okay, what investigation we will do? First of all, do the non-invasive investigation. First of all, non-invasive, then do the invasive one. So what are the non-invasive? Non-invasive is urine. Any child who presented with acute abdominal pain, it may be acute or chronic, please do the urine analysis, because most of the children suffers from UTI and we don't know, because there is not classical picture of burning, or the dribbling. These are the features of adult, but for pediatric, they mostly they complain abdominal pain. So do the urine test first, then from smaller to higher we will do full blood count, ESR, to rule out the infectious cause like ulcerative colitis, Crohn's disease, then blood culture, stool culture, then CRP, serum amylase lipase for acute pancreatitis, TTG IgA for his history of celiac disease. Then if there is a blood loss, okay, then do the blood grouping, and for future blood transfusion, consider pregnancy test. This is what very important. Okay, they will give you a scenario like a 14-year-old girl or 13-year-old girl is presented with 3-month amenorrhea and abdominal pain and vomiting. Okay, the following investigation are done, like increased beta hcg, urinary beta hcg, blah blah, like this. So the answer is the child is pregnant. Okay, so consider pregnancy test in any adolescent female presented with unexplained abdominal pain and amenorrhea. Okay, and of course CRP-WBC count is important to rule out any infection, like it can be appendicitis, it can be cystic fibrosis, celiac disease. Okay, any question until now? If you have any question until now, please ask. Any question? Okay,
Can we go
now
for this trend?
calprotecting. Calprotecting, if you suspect there is Crohn's disease or ulcerative colitis. Otherwise, this is not a basic investigation for abdominal pain. If you suspect, yes, of course, you will do calprotecting. Any more question? Calprotecting is an inflammatory marker. It is just like CRP. Okay. Any more question? Okay, so basic imaging. What basic imaging we will do? Abdominal x-ray. In certain situations, suppose the child presented with UTI, you will not do abdominal x-ray. But if there is a history of intestinal obstruction, or there is a history of any calculus, of course you have to do abdominal x-ray. Okay, and some x-ray we do by barium meal, barium follow through, barium enema. For Hirschsprung disease, we do barium enema. Okay, and some disease you must do abdominal ultrasound. Okay, abdominal ultrasound. And for renal problem, for testis and ovary problem, for pancreas, for gallbladder, liver, you have to do ultrasound. MRI of the abdomen and CT scan is very rarely done, but suppose there is a hidden tumor, there is mesenteric lymphadenopathy, okay, there are unexplained cause, you cannot identify any organomegaly, you cannot identify any cause, then you have to do an MRI, because there is a suspicion of mesenteric adenitis. It can be a case of tuberculosis, mesenteric lymphadenopathy. So you have to identify by CT scan, MRI. Okay, and suppose there is some pouch of Douglas tumor, or some tumors that is very rare in situation position, you cannot identify by normal ultrasound, you have to do MRI, CT scan. So CT scan and MRI we will not do in acute emergency, we will do in case of when the child is stable, when there is not an emergency, when there is available radiologist. We cannot do emergency basis. These investigations need expertise. Now sometimes if the child has a respiratory problem, then we will do chest x-ray, of course. And remember, if you suspect any abdominal emergency, surgical emergency, do not delay surgical review while awaiting for the scan. Do not delay. You urgently refer the child. Okay, suppose you are given investigation like x-ray, ultrasound, but the child is in shock, torsion of the testis, intersusception, so you cannot delay the referral, okay, for investigation. You will do investigation by the side by side, you have to refer the child to the surgeon. Okay, Now the management of management of abdomen. So if the child is in acute condition, hypotension, shock, manage that first. ABC, we know airway, breathing, circulation, then comes through disability. If surgical problem, stop feeding. This is general rule. Stop every child, NPO, nothing per oral, give IV fluid. Okay, anything like appendicitis, cholecystitis, or anything, just do NPO. Intestinal obstruction, just do NPO. Then if nasogastric tube, give a nasogastric tube so that you can drain the the excess amount of fluid so that the abdomen becomes soft. Okay, and in case of bile obstruction, the more the drainage, if the the secretion will come out in the abdomen, so you have to remove those secretion. And start IV antibiotic if you suspect any inflammation. Sometimes metronidazole is important. Why? Because it covers the anaerobic organisms. Now, what are the indications for surgical review? A localized right iliac fossa pain indicate appendicitis. Rebound tenderness or pain on percussion indicate appendicitis. Migration of pain. Suppose there is intestinal obstruction, then to relieve that obstruction, the pain will be like colicky and migrating. This force, this colicky nature of the intestine, they try to move the obstruction, so you will find migrating pain. And some pain will be referred from, like the pneumonia, basal pneumonia, the pain will be referred into the abdomen. Sometimes you will find refer pain. Red currant gel indicate there is advanced stage of intussusception. And bile stain vomiting, abdominal distension, ilioinguinal swelling, and pain is progressing in nature, or if you have any doubt. So these are the indication when you will urgently take all your surgical colleague. Okay. And what is the recurrent abdominal pain? Now, who can tell me what is the definition of recurrent abdominal pain? Can anyone tell me? What do you mean by recurrent?
Recurrent means for 3 months,
3 months.
repeatedly.
3 attack in 3 months.
Very good.
More
Very
than
good.
3 attack in 3 months.
Yes, Dr. Tanvir knows this thing because he's my old student. Yeah. And Dr. Rosina is also my old student. They know this thing. So 3 pain in 3 months. Okay, if the child presented. So this is called recurrent abdominal pain. And remember, recurrent abdominal pain may be organic, may be non-organic. Organic causes are 5 to 10%, and non-organic causes are main causes of recurrent abdominal pain. And if any child presented with recurrent abdominal pain, first you will try, if there is no red flag, suppose there is no red flag, like there is no vomiting, there is no loose stool, no loss of weight, you will try to reassure the parents and child, and you will give some laxative, increase fiber of diet. You will tell the child to take extra water so that there is no UTI. You will give some probiotics. Okay. Sometimes hypnotherapy, psychotherapy is very good. Hypnotherapy means, okay, this is very common at your age. Okay, everyone feels same like you do. Okay, so these are the hypnotherapy. Sometimes the mid-cycle pain, the child started the mid-cycle pain and they presented with recurrent abdominal pain, but it is normal mid-cycle pain. So you have to counsel the parents, the child. Okay, and sometimes you give dietary modifications, some fiber you need increase. So this is the management of recurrent abdominal pain. But if you suspect there is some red flag, please do not wait. We have to refer urgently. Clear? Analgesia is sometimes important, but remember, if the child is in severe pain, suppose acute appendicitis, the question may come like this: a child of severe pain in the right iliac fossa and rebound tenderness present. And now what is the first line management? Call the surgeon. Number 2 is oral morphine or IV morphine. The answer should be IV or oral morphine before calling the surgeon. Why? Because pain is just emergency as like airway, breathing, circulation. This is a palliative question. This is a pain related topic. Okay, remember, pediatric population, when they suffer with pain, this is an emergency. You have to improve the pain first. Do not withhold the pain that the surgeon will come and they will find no pain. No, don't do that thing. Okay, please give analgesia to the child, adequate analgesia. It may be opioid, it may be NSAID, anything. Okay, clear? Now, abdominal pain, how I will manage a child of abdominal pain? First of all, I will take the history. If the child is not in acute pain, suppose if the child is not in severe acute pain, it is like stable child, not in shock, I will take the history from the mother, like short history, when the pain started, how the pain started, is there any surgical condition, like is there any, the shock or perforation sign symptoms like this. If there is no surgical review, okay, then I will do urine test. I will check for fever. I will think it may be gastroenteritis, UTI, or maybe pneumonia like this. If I find this is appendicitis or surgical opinion is needed, I will not wait. I will imagine, I will send the child to the surgical consultation. And now, if the child has diarrhea or fever or vomiting, I will ask that is it blood mixed or no? Okay, if it is blood mixed, I will consider IBD or hemolytic uremic syndrome or intersusception. If it is not, there is no diarrhea, no fever, but the child presented with vomiting or weakness, I will think about maybe it is a case of pregnancy. I have to do urine for pregnancy test. Okay, but remember, for any adolescent child, okay, if you are doing pregnancy test, you have to take the consent from the child, because this is a GILIC competent child. You cannot do any pregnancy test, okay, without asking the child. Okay, remember, these are the ethical questions. And if you suspect, no, there is nothing, there is no blood, no nothing, just only abdominal pain, think about infrequent bowel movement, think about constipation. This is the most common after UTI, constipation and UTI. These are the two most common causes of acute abdominal pain in children. So remember, when you admit the child, okay, if there is no symptom of abdominal pain, then you can discharge within 1 day. And usually the follow-up should be given in primary GP care, okay, unless the surgical consultation is needed. If it is a medical condition, we will refer to the GP. Okay. Any question now from this guideline? So
Yes,
now I,
ma'am, I have one
yes,
question.
yes.
Ma'am, before you mentioned about the mid-cycle pen, what does it mean? In
It is
manage, yeah.
ovulation, ovulation
Sorry?
pain,
Oh,
ovulation,
oh, oh. Okay, okay, okay.
ovulation pain. Okay, this is here. It is written.
Dysmenorrhea.
Yeah, this is Mittelschmerz pain. Mittelschmerz pain. I don't know the actual pronunciation.
Yes, this one.
Mittelschmerz. Yeah, this one. This one. Okay, this one. This is the mid-cycle pain. And this, many adolescent girl will come to you with this pain.
Yes, yes, yes,
And
ma'am.
you will not identify what is this pain, the chronic pain, like recurrent abdominal pain, but this is happening in a particular time of the month. So this is like mid-cycle pain. Okay. Okay. Any more question? Okay, I will not now take bye-bye from the Facebook and YouTube. Inshallah, see you in our next topic. Till then, you can watch my YouTube channel for the free videos. Okay, everyone, take care. And now putting the recording. Just give me 1 minute.